where things were with the pediatric academic health system discussions. He could not make that Monday meeting, so instead he will be coming to Grand Rounds next week. We'll start his part of this at 7:15. We should be done with it by about 7:30, 7:35, and then go on to the regular Grand Rounds presentations. But I'd really encourage faculty, staff, whomever wants to hear about this. Now, there's no secret to arrive here at 7:15 next Wednesday. Okay, so thanks.
Good morning, everyone. Thank you for joining us today. I'm Kathy Bendel, and on behalf of the Equity, Diversity, and Inclusion Council, I would like to welcome our Grand Round speaker today, Dr. Brian Yablon. Brian needs no introduction to some of us, but for the rest of you, I will give some background. Brian grew up in Northeast Wisconsin and received his bachelor's degree in mathematics from the University of Wisconsin, so he's a Badger instead of a Gopher. But he spent plenty of time here. He earned his MD at Yale University School of Medicine, and then he completed a combined residency in internal medicine and pediatrics here at the University of Minnesota in 2011. So he spent a lot of time with us, because he then served as pediatric chief resident from 2011 to 2012 here at the university and at Hennepin County Medical Center. After that, he moved to Anchorage, Alaska as a CDC Epidemic Intelligence Service Officer, where he worked with the Alaska Division of Public Health on disease surveillance, tuberculosis control, outbreak investigations, and vaccination coverage. I remember talking with him about this as he was about to head out and thinking, wow, what an adventure. He stayed in Alaska for 3 more years as a hospitalist at the Alaska Native Medical Center, and then came back here to the Twin Cities in 2017 to work as a MedPeds hospitalist at Hennepin County Medical Center. He also currently serves as the board president for Physicians for a National Health Program, Minnesota. And in continuing our discussion of healthcare inequities, he's going to talk to us today about healthcare for all, the case for a single payer. Welcome, Brian.
Well, thanks for having me at Grand Rounds. And just some brief objectives. I want to explain what single-payer healthcare is and distinguish it from alternative models. Talk about a proposal called the Healing and Ailing Pharmaceutical System Proposal for Prescription Drug Reform. And then spend a bulk of the time analyzing some of the inequities and inefficiencies in our healthcare system, review how reforms would affect them and affect your patients. Financial relationships to disclose, and I will not discuss off-label or investigational use. So why, it's 2018, why talk about healthcare reform? We passed the ACA. And so I want to acknowledge that there were many gains made from the Affordable Care Act. Medicaid expansion here, not in every state, but Medicaid expansion in a lot of the blue states. And I think about 18 states have still not expanded Medicaid. Young adults can stay on their parents' insurance through the age of 25, but could still get kicked off at age 26. There are options for individuals who don't have employer coverage, who don't qualify for public insurance. They can go on something called the exchange, and they can buy a metal-graded plan. You can no longer be excluded from a qualifying health insurance plan if you have a pre-existing condition. And then there's something called the age band rating ratio that's been decreased, meaning that if you are an older person, you cannot pay more than 3 times the premium that a younger person can pay. And those are all positive reforms, among many others. But I also want to point out that, and no doubt you're aware, that there are some problems that have persisted and others that have grown under the Affordable Care Act. And meanwhile, a lot of the protections above, as well as other protections from the ACA, are constantly under threat or are actively being chipped away. So I wish I didn't have to tell you this story, but this happened a year ago. This is a Sentinel event in our own backyard. And you can see this was in the Star Tribune. This mom has been very public about what happened with her son, who died for lack of insulin related to high drug prices. His name was Alex Smith. His mom is quoted there saying, "You're price gouging people who need this one product to live, to survive." And Alec was diagnosed with diabetes type 1 at age 23. He had been on his parents' insurance and until he turned 26, which is in May of 2017, and he lost his coverage on the first day of the next month, June 1st, 2017. He worked as a restaurant manager, and his employer did not have a sponsored insurance program. And so he and his mom had been looking on the exchange months before in anticipation of this. And the cheapest plan where he could continue to see the endocrinologist that he had been seeing, which is a key, the cheapest plan where the endocrinologist was in network, had a $450 monthly premium, but had a $7,600 annual deductible. And so he elected to remain because he knew that it would take most of the year for him to hit that deductible, and he would be spending out of pocket for his insulin. But he didn't realize how expensive the insulin would be. He couldn't afford a $1,300 refill of his insulin, and so he began to ration his own medication at home while he was waiting for his next paycheck. And he was found dead at home less than a month after this. He was found dead at home on June 20, 2017, and an autopsy confirmed DKA as the cause of death. So, you know, if you're in hospital safety and quality, you know that a sentinel event has to demand a root cause analysis. And so what could have caused this? Usually it's some sort of perfect storm that leads to an awful outcome. So I want to start with this chart. And really all you need to focus on here, the left is 2014, the right is 2000. Red is a more restrictive type of plan, and this is on the ACA exchange. And so basically in 2014, just under half of the ACA exchange plans were considered very restrictive networks. And now it was over 2/3 of the plans in 2017. So again, this is sort of determinative of, can you see that endocrinologist that primary care doctor, that endocrinologist that you were already seeing. This is a graph of pocket costs on the ACA exchange plans, specifically the monthly premium. And in the green is 2014, and in the blue is 2017. And again, the bronze plans are the cheaper plans in terms of premiums. A bronze plan, literally what that means is the actuarial rating of the plan is 60% of your costs are going to be shared by you, as opposed to the insurance company would be 40%. And that's an actuarial average. Silver 70%, gold 80%, and platinum 90%. So you can see that for the bronze plan in 2017, $475 premium a month was right on par with what ALEC was seeing. And you can see for a platinum plan, gold and platinum, you know, you're looking at, and this is an individual plan, a huge outlay monthly. And what does that get you? So this is the deductible. So again, the cheaper plan per month has the higher deductible that you're more on the hook for out-of-pocket costs through the year. And so again, the plan that he was looking at, $7,600 deductible, that's pretty close to in line with the bronze plans of 2017 average of $6,014. This is just a graph of insurance company profits. The ACA was signed in 2009. You know, for any talk of, you know, the ACA was a takeover of the insurance companies, you know, I defy you to explain that looking at this graph. And this is just you know, this is a single payer talk. I have to show you a slide of Health Insurance CEO Pay in 2017 for the largest health insurance companies. And those are in millions of dollars. And this is a graph of insulin prices from the mid-1990s through July 2016. This is Humalog and Novolog. I mean, a few interesting things. One is that this is rapidly rising over the last few years. And also the second interesting thing is that these are two different products, different manufacturers, but the prices somehow are rising in sync. And this is Lantus and Levemir, same story, from 2001 to May 2015. So can all of these sort of explain that perfect storm of Alec's tragic death? You know, maybe. But even so, what could justify it? So I'll give a second disclosure. I serve voluntarily on the board of Physicians for National Health Program Minnesota. We are a 501c3 that's dedicated to building a movement to create an innovative healthcare system that will cover all Minnesotans in an equitable and economically feasible manner. And we're a subsidiary of National PNHP, which was founded in 1987. And this is the PNHP mission statement. We don't have to go through all of this, but basically we believe healthcare, high quality healthcare is a right of all people. We educate physicians and other healthcare workers in the general public about the importance of comprehensive, high quality publicly funded healthcare. Equitability is a key tenet and principle. And we view that as meaning removal of all barriers to adequate healthcare currently faced by the uninsured, the poor, minority populations, and immigrants, both documented and undocumented. And we view this as a part of a larger campaign for social justice. I want to talk about what equity means. The American Public Health Association defines it as everyone has the opportunity to attain their highest level of health. And so inequities are created when barriers prevent individuals and communities from accessing those conditions, reaching their full health potential. And social determinants of health are mostly responsible for health inequities, which are unfair and avoidable differences in health status. So just my experiences with health inequities, I went to med school in Connecticut. I spent a summer of that time in South Africa, and there's a huge amount of global health experience here at the U. And so global health equities are really outside of what I'm going to be talking about today, but that informed a lot of my perspective. And I spent a good amount of time in medical school working as a volunteer clinician at a student-run free clinic, and did the same in residency here at the Phillips Neighborhood Clinic, and saw a lot of people who were just falling through the cracks of the system, people who didn't have insurance, undocumented individuals, and people who were getting, quite frankly, no access to care through the conventional system or getting substandard care through a student-run clinic. I did a public health fellowship in Alaska, and part of that time I spent looking at vaccine disparities and seeing socioeconomic and racial disparities in vaccination coverage. And then worked as a clinician there in a system that actually is kind of analogous to the VA. IHS gives sort of a block grant fund, but that does not adequately cover the budget of the Alaska Native Tribal Health Consortium, which also bills private insurance. The patients that I took care of never had any out-of-pocket costs, which was fantastic, but on the whole, the system definitely suffered from being underfunded, though it is the flagship of the native healthcare system. And when you look at the kind of quality of care that is available on native reservations in the lower 48, it's not comparable. And today I work back at HCMC with Gail and some of the other people here, and I can't go a week without thinking about these kinds of issues because I see uninsured and underinsured individuals, undocumented immigrants every week that I'm working in the hospital. And I talked about this is not a global health talk. So health inequities occur along many lines, and these are just some of them, but really anything you can think of can cause a health disparity. And the social determinants of health, the left is sort of the most general economic, and on the right, you get down to our healthcare system. And so health coverage is just one piece of what determines your health. Although in our system, I will just point out that employment, income, those things are definitely wrapped up with health insurance in the United States. And so there's a lot of interplay among these different levels. Medical bills is another thing that's over in the economic side. So in terms of health equity and insurance, a lot more than health insurance is going to determine whether someone will achieve good health. I think we can all agree on that. But our health insurance system, which we don't really have a system here, erects barriers that perpetuate disparities and thwarts equity. Through a lack of insurance, through churning, and I'm not sure if that's that people have heard of, but churning just means when you go from having insurance to not having insurance, or one type of insurance to another type of insurance, where you can kind of go in or out of a network, have to meet a new deductible. Through underinsurance, the copays and deductibles and premiums that I was showing you. Through differential reimbursement to healthcare facilities that serve the underserved. The hospitals talk about something called a payer mix, and they want a good payer mix so that they can have a better operating margin. And when you have a better operating margin, you can invest more in the kinds of things that your institution wants to do. And so that's just a more subtle way, but a real way that that kind of the rich can get richer in our country, and that the underserved continue to be underserved. And all of this happens while a lot of people who profit off of the inequity in our system. This graph shows a survey of insured Americans. So again, not talking about anyone who's uninsured. Among the insured, how easy or difficult is it for you to afford to pay? And again, 2015 is on the left, 2017 is on the right, each group. So in terms of a monthly cost of health insurance, monthly premium, 37% of respondents, this is a national poll, Kaiser Family Foundation, 37% of respondents in 2017 said it was difficult for them to pay for their monthly premium. 2017, 31% said it was difficult to afford copays for MD visits and prescription drugs, and 43% said it was difficult to meet the deductible for care before their insurance kicked in. And another poll around the same time frame in 2017 asked, in the past 12 months, did you or anyone else in your household have problems paying or an inability to pay any medical bills? And 29% did have a problem or difficulty paying a medical bill. And when you looked at that, 17% of people had a major impact and 11% had a minor impact on their household from medical bills. And again, these are all insured people. Actually, sorry, this one, it was not necessarily just insured people. And people make troubling trade-offs to pay the bills. And so specifically they asked, well, what happens, what have you done to try to pay the bills? And so 73% have cut their household spending, 71% have put off major household purchases, 61% use up all or most of their savings to pay medical bills. And again, this is of the 29% who said it was difficult. And then quite a few borrowed money, took an extra job, increased their credit card debt, changed their living situation, and then you look down at the bottom, taking out additional loans, including another mortgage on your house or a payday loan to pay medical bills. And all of those things can cause a lot of trouble, obviously. In addition to the financial burden, people skip care. And so in the past 12 months, have you or a family member done any of the following due to cost? And basically 1 in 3 people skip dental care or dental checkups because of the cost. And then nearly the same number relied on just home remedies over the counters instead of going to see the doctor when they thought they had a problem. Put off or postpone getting needed care. Not filled a prescription, 1 in 5 people. Cutting their pills in half, 1 in 6 people. And 1 in 8 people, remember, not everyone needs mental health care, but 1 in 8 people had difficulty accessing mental health care because of the cost. In terms of a personal financial impact, you can lose work time, lose earnings, you can lose your job, which could create a sort of death spiral where you lose your insurance, and people can get medically bankrupt. And medical bankruptcy is the #1 cause of individual and family bankruptcy in the United States. And these effects happen whether or not you have health insurance. It's obviously a bigger problem if you don't have health insurance, but for some of the reasons that I've already shown you, it definitely happens to people with health insurance. And the majority of medical bankruptcies, people were insured at the start. So shifting gears and talking about who is most impacted by out-of-pocket costs. So this slide just shows median U.S. family wealth. It's pretty dramatic by race. So the median white family in the United States has a wealth, all assets of $171,000. The median black or African American family, about 1/10 of that, $17,409, and the median Hispanic family, $20,900. And again, so thinking about if you have an unexpected cost, if you need to tap into your social network, who's more prepared, who's less prepared on average to meet that, who's most impacted. This is a similar situation for retirement savings. This is specific to Minnesota. The median household income for white Minnesotans is $68,700. For American Indians is $37,000, and for black Minnesotans is $33,000. The childhood poverty rates are more than 5 times for American Indian and for African American Minnesotans. In terms of home ownership, there are disparities nationally, and this graph shows that they're worse in Minnesota. They are, 76% of white non-Hispanic families in Minnesota own a home versus 24% of black families, and again, a lesser percent of Hispanic, Native American, and Asian families. Homelessness, the 85% of the residents of Minnesota are white, but 38% of the homeless residents of Minnesota are white because there's a disproportionate number of black and Native American and Hispanic homeless residents in Minnesota. So again, all of this is just to say that disparities can compound each other. Socioeconomic disparities that are already there and that have numerous causes mean that there are people who are a lot more vulnerable to being victims of a patchy healthcare system or who are not going to be able to afford out-of-pocket costs. And this really drives that home. This is a survey that said, what is your ability to cover an unexpected $400 emergency. And meaning, can you pay in cash or by credit card that you pay off at the end of the month? And it's stratified by family income, less than 40,000, 40 to 100,000, or greater than 100,000, and then also stratified by race. And you can see at each income level, probably in large part because of these wealth disparities that are not tracked with income disparities, the white family was more able to cover that expense than the black or Hispanic family. And again, this shows disparities, but incomes are not evenly distributed, and so the disparities are even worse. So this is the income disparity itself. And so when you actually think about in the United States who would be truly able to cover a $400 out-of-pocket emergency, there's probably a 25% discrepancy between white and black families, and over 20% between white and Hispanic families on average. And again, Minnesota, the income disparities are worse, and so probably this disparity is worse. Minnesota, we take a lot of pride here on our safety net and our public social services. And it's true that we do a much better job than a lot of states, and we have a lower uninsurance rate than a lot of states. But I'll just still point out that there are 330,000 uninsured individuals in Minnesota, 6.1% of Minnesotans uninsured, 4.2% of Minnesota children, and 17.5% of foreign-born individuals in Minnesota are uninsured per the American Community Survey in 2016. When you look by race, the uninsurance rates are 5% among white Minnesotans, over 10% among black Minnesotans, 19% among American Indians, and nearly a quarter of Hispanic Minnesotans. We can look right here in Hennepin County, and the disparities are even greater. Under 5% uninsurance among white residents, 11.7% among black residents, and 28% among Hispanic residents of Hennepin County. When you look by education level, if you've completed a four-year bachelor's or more, like most of the people in this room, 2.6% uninsurance. If you look up to people who have not completed high school, 22.5% uninsurance. And that's in Hennepin County. So how has all this affected the patients that I take care of? So I saw a gentleman in the last year who had a swollen airway. He was in his late 20s. He was diagnosed with angioedema, and he needed to be intubated and was transferred out of the ICU. And that would be pretty scary for most people. For him, it was not that scary because it had happened to him multiple times. He had a condition with recurrent, I believe, hereditary angioedema. He had certain stressful triggers. He had seen an immunologist. He'd been recommended for a biologic therapy. And that therapy was not going to be covered by the insurance plan that he could purchase off the market. He worked at a bar or restaurant, didn't have employer-sponsored insurance, sort of intermittently qualified for Medicaid. And so he just kind of took his chances. He knew this was going to happen. He knew he couldn't pay, and he'd just come in and get emergency care for his airway swelling. I saw a gentleman who was 64. He had stubbed his toe. He was born outside the U.S. He was no longer working. He was a middle-class guy from a country that has universal health care. He sort of self-managed his toe, just didn't think it was a big deal. It got a lot worse. It started getting swollen and purulent, and so he went in for that and for the excruciating pain, found out that he had osteomyelitis and also undiagnosed diabetes with a hemoglobin A1C of 12%, was recommended for an amputation, waited because he wanted to wait until he turned Medicare age, ended up losing a good part of the foot, ended up having vascular disease, acute kidney insufficiency, a much more protracted and complicated course. And again, because he knew that he wasn't going to be able to afford his treatments, or he didn't have confidence he was going to be able to afford them until he turned Medicare age. A preventable asthma hospitalization. I mean, this is a thing I see all the time, but in the last couple of months, I saw a 13-year-old hospitalized at HCMC for an asthma attack. They knew he had asthma. They knew he was supposed to be on a controller inhaler. His mother had lost her job 6 months earlier. They couldn't afford the inhaler anymore. They just figured they'd ride it out, and he was admitted with an asthma attack. And maybe he would have gotten one anyway, but that was the reason he wasn't on his inhaler. I saw a 6-month-old infant with pneumonia, and she had no vaccinations. And the reason she was unvaccinated was not because the parents had any problem with vaccinations. She'd actually gotten a birth dose of hepatitis B. The reason was that the family had gotten a $2,000 bill from the birth hospital that they couldn't afford, and so they just didn't come back to care. And so their child was falling off the growth curve, was not developmentally normal at 6 months, and had not gotten immunized, and did come into the hospital with pneumonia. And then a gentleman who is in his late 20s who had a painful tooth. He was homeless. He didn't have the ability to go see a dentist financially, wrote it out. Eventually his face got very swollen. He got fevers. He did go in to see the dentist after a few weeks. The dentist sent him immediately to the emergency room, gave him some clindamycin to go to the ER. He had an abscess that needed to be drained by an oromaxillofacial surgeon, and he had endocarditis. I sort of informally polled a few people in this room and a few people I work with at HCMC, how has this affected your patients? So I found out about a patient with pancreatic insufficiency who had a Whipple procedure, who's not able to access the enzymes that they need to digest food and therefore to grow, because the insurance doesn't cover it for that particular condition. If they'd had CF, it would be covered. A Crohn's patient on steroid-based therapy or steroid-only therapy, which is suboptimal because they're on a kind of co-op insurance plan, which does not conform to the ACA because they can't afford a plan off of the ACA exchange, and is not going to be able to afford the biologic therapy that would otherwise be recommended. I've heard about incomplete LTBI therapy for children whose Medicaid, Minnesota contracts out Medicaid to various private insurers. And sometimes those go up for bids, and when those go up for bid, your insurance can just change without you even realizing it, or you get a letter in the mail that you don't understand. So I've heard about children who were on LTBI therapy through one provider, lost access to the provider, and then the LTBI therapy just stopped, which, having worked in TB control, I can tell you is not a good thing. It can definitely breed resistance, and is playing with fire. Heard about a teenager with a delayed lymphoma diagnosis with now higher risk disease, who presented after a 40-pound weight loss and symptoms for a much longer period of time, and the family knew there was something wrong, but had moved from a different state, didn't have insurance, and sort of waited to seek care. And a potentially preventable eye enucleation in an infant whose parents saw that the eyes were asymmetric, knew there was something wrong, sort of waiting on an insurance gap to be fixed, and this child had a retinoblastoma, and maybe the eye could have been spared. Hard to know in retrospect. In terms of how this has affected your clinics, again, many people, when I came back to HCMC, were talking about when Medica pulled out of the Medicaid program, children lost access to their primary care provider. They were reassigned, let's say again by a letter in the mail that they didn't understand, to a different program such as Health Partners, couldn't see their primary care provider at HCMC anymore. And that's a big loss. I've heard about people seeking or avoiding care based on where they sit with the deductible. So basically waiting the first few months of the year because they don't want to pay out of pocket, and then sort of batching visits at the end of the year. And similarly for stocking up on medications before the end of the year, once they've met a deductible. I've heard from several people about hours of staff time that, often your RN staff are working on prior authorizations or peer-to-peer review referrals instead of actually coordinating care. And then families under significant financial stress, confused about bills, overwhelmed, some using, for very expensive treatments, using crowdfunding, which is very common for children and adults nationally, the sort of GoFundMe and other sites to request funds to pay for healthcare or to pay for costs associated with healthcare. So our system is inequitable, but it's not merely inequitable. It also achieves worse health outcomes than other developed countries. It's expensive and it's administratively wasteful. In international comparisons, we rank 31st in life expectancy, 36th in health-adjusted life expectancy. We are 40th in infant mortality with 5.9 deaths per 1,000 live births, and we're 45th in maternal mortality. And a lot of these low rankings are driven by health disparities in the United States, because we know that there are significant racial disparities for infant and maternal mortality as well as life expectancy that are driving those rankings much worse for us. Compared with many other developed countries, 10 other developed countries in a 2016 study, we had the lowest life expectancy, the highest infant mortality, the highest obesity rate. We actually had the second lowest smoking rate, interestingly enough. And again, as I just mentioned, many of our poor outcomes are exacerbated by health disparities. Compared with these same countries, we had the highest healthcare spending as a proportion of our GDP. We spent 18% compared with 9.5% to 12.5% elsewhere. We had the lowest insured rate. It's basically, in any of those countries, it's almost unheard of to be uninsured. 99 to 100% coverage, 90% coverage here, which is an improvement, again, from before the ACA. We had the highest drug prices, $1,443 per capita versus 400s to 900s elsewhere. And that is not because we are more drugs. It's because we pay more for the drugs that we are prescribed here. And we had the highest rate of cost. And this paper quoted 8%, although a New England Journal paper probably more accurately, when you look at the full spectrum of administrative costs on the insurer and provider ends, estimates 30%, versus, again, 1 to 3% administrative costs elsewhere. And we also have the highest healthcare professional salaries, but we also pay a lot for medical school, which most of those other countries don't. So that's a caveat. I'll point out that we're not overusing healthcare. There's a lot of talk and a lot of myth about us excessively utilizing and that driving up the price of care. But when they looked again at these other countries, we did not utilize any more healthcare, for example, these diagnoses or any other diagnoses. And so it really was the prices that accounted for our high healthcare spending and not excess utilization. So what is single payer? I'll very simply just explain the idea. So equity, everybody is in the system, nobody's out of the system. Comprehensive coverage, and that includes medical care, dental care, which is so important and so missing for a lot of people these days, mental health and substance use, long-term care. It's first dollar coverage, meaning no out-of-pocket expenses incurred at the point of care, progressively publicly financed, and there's no networks. There's free choice of doctor or provider. Single-payer savings, international comparisons that I just showed you demonstrate this. Economic models within the U.S., which are cited below, and within Minnesota demonstrate this, huge savings. And it achieves these savings by reducing administrative burden, eliminating insurance profiteering, global budgeting for hospitals, bulk drug price negotiation, and bending the cost curve, which has not really been done under the ACA. And it does not, importantly, it does not achieve savings by reducing the care that people receive or erecting barriers to care. Single payer is popular. 60% support in an April 2017 public poll, 24% opposed. And among physicians, it's popular. National polls have shown huge increases in the last decade in physician support, with 56% of physicians supporting in 2017. And a poll in 2008 showed that it was most supported by psychiatrists, pediatric subspecialists, and ER doctors. And I would speculate it's because those providers are seeing some of the most vulnerable people who have some of the highest cost care. But that's just a guess. They didn't ask that in the poll. And again, that was in 2008. And if the secular trends of national physicians are an indication, then probably support is increased among those groups. There was a Minnesota poll done by Dr. Oberg and colleagues about 10 years ago that also showed majority support in Minnesota. And increasingly, single payer is becoming popular among legislators or people who want to be legislators and want to be your representatives. So there are single payer bills on the table. In Minnesota, the Minnesota Health Plan, chief authored by Senator John Marty and Representative David Bly, and those are the bill numbers. And nationally, the Expanded and Improved Medicare for All Act, which is in the U.S. House, H.R. 676. It was sponsored by John Conyers, who's no longer in the House, but is chief sponsored by Representative Ellison now, and will need a new sponsor since he's leaving Congress. It has 122 co-sponsors, which is 60% of the Democrats in Congress. It does not have any Republican co-sponsors. In the U.S. Senate, Bernie Sanders introduced Senate Bill 1804 last year, and there are 16 co-sponsors. And that bill is not considered the gold standard single payer bill. H.R. 676 is still considered the gold standard single payer bill, mainly because the Sanders bill does not include global budgets, long-term care, and it doesn't eliminate co-payments for drugs. The Minnesota Health Plan does include global budgets, eliminates co-pays for drugs, and does include long-term care. So I'm going to shift gears and talk about a proposal for healing an ailing pharmaceutical system. And the motivation is that obviously, drug prices are out of control. There's some very misaligned incentives in terms of drug development, and single-payer reform alone is not going to address all of the problems. So this guy's picture shouldn't be on this. It should be on the next slide, and that is not Matt Ambrose, who I'm looking at here. That's his evil twin. Okay, so this is the Epipen. Yeah. So the Epipen was $100 in February 2017, and it was $600 in February 2016. And this is, I know you're all aware of this. That guy, again, his picture should be here. He's the one who increased the price of Daraprim from $13.50 to $750 from 2013 to 2015 because he could. I mean, that was really the reason. And you can see doxycycline, all of these long-standing generic medications had huge price increases from 2013 to 2015. These are the profits. When you look at Fortune 500 companies and you separate them out by pharmaceutical companies and other types of companies, drug firms, the profits were like 23%, and the other firms it was 7%, which is still a really nice profit. 7% is a nice profit. So this just goes to show these companies are not hurting. They're spending far more on marketing and administrative expenses, more than $100 billion a year, than they are in research and development expenses. And that's per their own figures, so take that with a grain of salt. Pharmaceutical Company CEO Pay in 2017, again, very similar to the health insurer CEO Pay, and just because I have to show this to you, so. And this is the amount that the pharmaceutical industry spends on lobbying in the U.S. 2018, it's less so far, but we're not done with the year. But you can see upwards of $240 million in 2017 spent on lobbying. When I looked at Open Secrets this morning, there are nearly 1,200 lobbyists employed by the pharmaceutical industry. Of those lobbyists, 63% are considered revolvers. And the figure is very similar for the health insurance industry. And what that means is that if you're a revolver, you are someone who's taken a job with a lobbying group and then also worked for the government. Also worked for a congressional staff or worked for a department of government. So the majority. And look no further than who is currently heading our Health and Human Services Department. So healing and ailing pharmaceutical system. Single-payer systems can bulk negotiate for pharmaceuticals, and that is very helpful in lowering prices. We are currently disallowed. Medicare is not allowed to negotiate for drug prices, and that dates back to the Bush II administration. There was basically because it was going to be included in legislation that Medicare could negotiate for drug prices. And then there was a legislator who said, nah, let's not put that in there. That's not really necessary. We'll be able to keep drug prices down in other ways. So they didn't put it in there. It passed. You can't negotiate drug prices. And that legislator left Congress, and became, the CEO of Pharma that year. So, again, bulk negotiation would be very helpful, but additional pharmaceutical reforms are needed to improve access, cost, and quality. And so PNHP convened a blue ribbon working group of U.S. and Canadian physicians and pharmacists and other experts to outline the best path forward. And so these are slides taken from PNHP. So access. So drugs need to address medical needs. Medical needs, not finances, should determine your access to drugs. Affordability. They need to be affordable, whether to the individual or to society as a whole. We have to be able to innovate, apply the innovation to maximize population health. A health-first approach. Health has to take, when there's a conflict between health and patents, health has to take precedence. Medications have to be well tested. And there has to be honesty and communication about results of clinical trials. So in terms of the access piece, already reviewed sort of at length high out-of-pocket costs and why drugs are unaffordable to a lot of people. So one solution is to establish a national formulary and then provide all residents with full coverage of formulary drugs, which you can do in a single-payer system, and then eliminate copays and other cost sharing. And that formulary has to have a mechanism so that if you can't take the drug on the formulary, you need a different drug, and that can be overridden, and then the second choice drug would get taken. Lower drug prices. So our drug prices, again, are rising far beyond the cost of development and production. I think the Daraprim and doxycycline graphs illustrate that. So we have to be able to negotiate with patent holders, compel people who are price gouging to license their patents to generic manufacturers, and when necessary, in the case of shortage or emergency need, allow for public production of critical drugs. And this has already been, threatened a couple of times. For example, ciprofloxacin, after 9/11, when there was the concern for anthrax attacks, ciprofloxacin prices were very high. The U.S. government said, drop the prices. The company said, we're not going to drop the prices. And then they said, well, we'll just manufacture the drug. And so then they balked and cut the price in half. So reforming our drug development process. Today's patent process keeps prices high and discourages innovation by allowing a lot of Me Too drugs, minor tweaks, changing a little bit the vehicle for the insulin, which allows you to keep it on patent and to keep the price high. So denying patents for trivial changes and limiting market exclusivity to clinically superior drugs, publicly funding and supervising the majority of clinical trials, and using public agencies to develop new non-patented drugs. And then this final point is very important because a lot of you do basic science research. I do not do any basic science research, but a lot of you do. And that's publicly funded research. And pharmaceutical companies largely are in the business of taking NIH-funded research that's happening at academic medical centers all over the country, including public universities and private universities, and sort of cherry-picking things and purchasing them at a point where they can then move on to clinical development. They're not doing the basic research. They're really just kind of getting it to market a lot of the time. And so there was a piece of legislation in 1980 called the Bayh-Dole Act, which allowed this, and not just for pharmaceutical companies, but allowed patents for publicly funded research to be taken by private companies. And so stopping that would enable much better negotiation, public production, and keep prices down. Independent clinical testing. So private drug firms own their data and can sometimes hide safety concerns that come up at this point. And so publicly funding the majority of clinical trials would address that. Higher standards for approvals, increasing data transparency, and then strong monitoring after drugs reach the market. And then tightening the approval process. There is currently a lot of funding by the drug companies themselves. Again, the HHS, the person who runs HHS was a former drug company CEO. And there's a lot of expedited approvals. There are certainly circumstances where you would want a drug to be approved expeditiously, but that's in a minority of cases. But you can basically pay to have your drug fast-tracked for approval in the current system. So fully fund regulators with public money, not industry user fees, less frequent use of these expedited reviews, and restricting advisory committees to experts who do not have financial ties to drug companies. Post-marketing surveillance. So again, increasing the funding and authority for regulatory agencies, post-marketing monitoring programs, and then promptly perform post-marketing studies. There's a requirement to do post-marketing studies, but these often don't take place or there's a huge time lag. And then honest communication. So marketing by the drug companies exceeds their R&D budgets, the graph that I showed you, and that's poorly monitored. So funding a regulatory review of drug ads, penalizing misleading promotions. Pharmaceutical companies can currently get tax deductions for their advertising and marketing, so that would be a great thing to stop. And prohibiting drug firms from funding education and guidelines. So all told, the single-payer reforms that I talked about, the pharmaceutical reforms, they would represent a giant step towards health equity. And again, I don't want to come in here and tell you this is a panacea, this solves all health disparities, this puts us on solid footing, forevermore. But it would be a giant step. They do level the playing field dramatically on access, cost, and quality, and that allows us to better move the needle on other social determinants of health. And as I mentioned, this is part of a broader movement for social justice. So I want to thank you, and if you are interested in learning more, you can check out pnhp.org or pnhpminnesota.org. You can contact me, and our next general meeting for the Minnesota PNHP is on August 16th. So happy to take questions.
Brian, thanks. Thank you. Thanks for that talk. Could you say something about the stances of the DFL candidates for governor on single payer?
Yeah, so I in my role as on PNHP Minnesota, I'm not in a position to endorse any candidate, but I can say that one of the candidates for governor, Aaron Murphy, is currently a sponsor of the Minnesota Health Plan, the John Marty single payer bill, and is endorsed by the Minnesota Nurses Association, which is pro single payer, and talks about single payer in all of her speeches. The other candidates have not really come out explicitly in favor. They haven't taken definitive positions.
Terrific. Thank you very much. Just to follow up on that, have any states actually gone to the point of enacting a single payer program? And if so, how did they do it? If not, what are the barriers at a state level in doing it?
So the question is, have any states implemented a single payer? The closest state Vermont came very, very close to doing a single payer system. Vermont was a special case because it's a very small state and a lot of people get care outside of Vermont and also are employed outside of Vermont. So in terms of like an economic model, it was never going to be a great model. And that bill also got pretty diluted. So that didn't exactly get off the ground. The California has come a vote away from passage, and basically the bill SB 562 in California was tabled by the Speaker of the House. I forget if it was the Speaker of the House or the head of the Senate, but it was tabled because they didn't want it to go forward. But it's basically been like a vote away in California, and in New York State, it's also considered to be kind of on the brink of passing a single payer proposal. In terms of barriers, same barriers at a state level as nationally, in terms of intense lobbying by insurance companies and pharmaceutical companies. Yeah.
So,
Gail.
Yeah. So I have a question about rural hospitals. You know, I think that obviously we're focused on urban centers and health disparities, but you know, there was a report recently on NPR about rural hospitals closing and people not having access to healthcare. You, I'm sure, experienced that when you were in Alaska. How does this single payer, does it address that at all in terms of, you know, rural healthcare and access to rural hospitals?
So the idea is a hospital develops a global budget, submits that budget for the care that they need to deliver. And usually that budget is going to be based in large part on what they spent during the previous year. But it would also depend on local health needs. And so, you know, the Marty plan, I think, very nicely lays this out, that you determine the health needs, including the staffing needs, you know, any gaps that are currently there. And if that means that in your rural area, because you don't have a psychiatrist, you need to pay a psychiatrist more, or you need more resources, that you would be able to request and get those resources. So this, in my opinion, would be a huge boon for rural hospitals. And also in terms of the network limitations that currently exist, and the fact that a lot of people in rural areas don't have sort of traditional jobs where they get access to employer insurance, and therefore get more uncompensated care. If they were covered under a single payer system, that would also be hugely helpful in rural areas. Yeah.
So the actual payer system pays for the hospital costs? I mean, that's part of the whole system, is that supports the cost of the hospital?
So the costs of the hospital under a global budgeting framework get separated into an operating budget and a capital budget. And so the single payer funds the operating budget of hospitals and negotiates with individual hospitals. The capital budgets have to be separately approved. And that's a way of, again, reining in costs. Like, do you really need that, like, 10th MRI suite in your metro area? You know, things like that. So, yeah.
So, Brian, could you talk a little bit about the difference between single payer and mandatory health insurance? You know, and, you know, Germany's got multiple insurance companies, but mandatory health insurance, and scores very highly. In England, other places, it's really a single health system.
Mm-hmm. So there's more than one way to get to universal coverage. And so Dr. Nagley was saying, Germany has private health insurance. They have mandatory coverage. England has a national health insurance system, which is really more similar to the way the VA operates. In Canada is more similar to the way that some of these single payer models here would look. And so we've had, in terms of a mandate, the Affordable Care Act had a mandate, which is now sort of defunct. And that, you can see that there's still a huge amount of uninsurance here because of the mandate. In Germany and in other countries like Switzerland that still have some private insurance models, those companies look nothing like private insurance companies in the U.S. They're extremely tightly regulated. They're much more accountable. They have no kind of profit margins the way that health insurance companies do here. They have to spend much more on care. And so you're basically talking about a completely different model than our private insurance industry is. So I think, yes, there's more than one way to achieve universal coverage. But if we're going to have to make a significant radical change, single payer gets the most administrative gain, the most efficiency, and again, it gets rid of things like networks. So.
My question is about the cost of drugs. It's relevant to that anyway. So recently the DoD paid for a study to evaluate the potency of drugs that they had been stockpiling in warehouses, but worth billions of dollars, but had passed their expiry date. And apparently about 97% of these drugs were still just fine. And of course the drug companies, put an expiry date on them because they're not going to pay for more studies to study them 20 and 30 years later. So what can be done to address that?
In terms of what can be done to get rid of or lengthen expiration dates?
Yeah. Because that's, a lot of stuff just ends up down the drain because people think they're no good anymore.
Well, I'm still carrying my 2014 Epipen. So, that's beyond my, I think as part of a major overhaul, especially if you're doing generic manufacturing of drugs, I think those kinds of studies could be done. And then, there would be potential to say, actually the shelf life is twice as long as you thought it was, but that's really kind of outside of my expertise. Not that I have any particular expertise. Okay, yeah.
I've always been curious about, and I don't know if you've thought about this, that these companies like United Health Group are huge employers. Like in the state of Minnesota, it's probably hundreds of thousands of people that they employ. So do these studies sort of look at, if we really went to single payer in Minnesota, how would that affect all the people who work for UHG and Blue Cross Blue Shield, et cetera? Yeah.
So the question is, a lot of people work for health insurance companies. What would happen to the people that work for health insurance companies if we move to a single payer system? So the studies have looked at this, in terms of they've looked at economic gains and economic losses, and in no transition, is everything positive. And so definitely if you're not having private insurance companies operating the way that they are now, or if they go away, then a lot of people no longer have those jobs. And so there is a provision in each of the serious single payer bills for sort of addressing that in terms of ensuring adequate compensation in a transition time, job retraining. A lot of people who work for insurance programs, insurance companies actually have a medical background, and a lot of people who are doing administrative work in your clinic can do clinical work. And so I think if you cover people that are not currently getting health care and you meet the needs that are there, a lot of people could transition into actual health care jobs. But in terms of, so yes, some people would lose their current jobs, and that certainly could be a sort of political barrier when you think about implementing a single payer system. I think on the flip side, people who lose their jobs in that scenario, because people lose their jobs all the time now, and go between jobs and change jobs. When that happens now, you lose your health insurance. That would not happen. That would be a big benefit. And I don't mean to be glib about that. I mean, that was a huge stress. I've changed employers multiple times in the last 5-6 years. I was on TRICARE in the U.S. Public Health Service. I took a brief hiatus before I started a hospital job and bought in a plan on the exchange. Was then covered by a different employer, went on COBRA, thought I was on COBRA, got bills for a period. So I understand this transition, and it's extremely nonsensical, stressful, what have you. So I think that would be a huge gain. But yeah, I think there's no sugarcoating that if you work in the health insurance industry, when I put up CEO pay and profit numbers, that doesn't imply that if you work for a health insurance company that you're not a good person. We don't all have free choice in terms of like pursuing a job that we love or that gives us personal fulfillment. And again, I think there would be transitions, and I would hope that the majority of those people would be able to retrain into a different kind of job and would be economically compensated. No? I can't hear.
The Loon Group study, we actually have the number of people, but we know pretty closely how many people are involved in the administrative side of the health of the medical industrial complex, 42,800 in Minnesota. And that is actually about a third of the number of people who change jobs every month in Minnesota. We feel as though that, I'm with Healthcare for All Minnesota as a volunteer, feel that we could pretty easily reemploy most of those people. The bill that Dr. Yablon referenced in Minnesota calls for a 2-year transition period, very generous with health insurance coverage. So this is not an insurmountable problem, but it gets brought up as a barrier frequently. And the idea is that you're going to be stopped by you're just going to be shut down by the idea that, well, what about all those people who work for industries change all the time, and nobody asks, what about those Blockbuster video store people? And the entrepreneurial activity that would result from providing health insurance coverage would probably vastly outweigh the numbers of people who would lose positions related to this change.
Thanks. Augie.
There's a lot of pseudo single payer bills running around, and especially getting commitments from candidates before primary season in Minnesota next month. There's about 5 different ones, including Medicare Extra for All from Center for American Progress. I'm wondering if you could speak just a little bit about some of these counter proposals that have popped up that don't quite get us to single payer and what some of their limitations are.
So I will identify you. That's Augie Lindmark, who is a medical student at the University of Minnesota and is on the Board of Physicians for National Health Program. So his question was, what about these look-alike mimic bills? A lot of people are starting to use the language of single payer because of the polls that I showed you, that it's gained in popularity, and because of the very real possibility that this could actually happen. And so people who don't want this to happen are starting to slap that label on measures that fall short. And so the Medicare Extra for All is one example of a bill that's not a true single payer bill that keeps that multi-payer model. And some of the names for these bills look strikingly like the names of the national bills. Rebecca Otto had a proposal called the Healthy Minnesota Plan instead of the Minnesota Health Plan, and that is not a single payer. It was, at some time she was using that label, but again, it involved multiple payers and large health systems. It was different. So yeah, I think that's something to be cautious for, and while you're learning more about this, to say, what the devil's in the details of these bills. And I think it's important to ask, what principles do you stand behind when you're supporting a position, and how will you ensure that that is not going to get really watered down or tainted in the legislation?
Yeah. You have time for one?
Sure.
Well, thank you, Brian. You've really presented a compelling argument. You've provided tons of data. The polls seem to say that people really want this, and maybe there is some momentum towards it. That all sounds great. And at the end of the day, when you look at what's in the media, man, this is un-American. It's socialism. And how do you overcome that kind of prevailing wind?
Yeah.
Not by tweeting, I hope.
Yeah. So I'm not on Twitter. So how do you overcome the sort of the hysteria of like, this is a socialist takeover of the United States? Didn't our president just sort of meet with who hasn't our country already been taken over? So this is not socialism. Anytime you ask a question like that, you're not supposed to say this isn't socialism, because then immediately it feels like you're endorsing socialism. In terms of these same accusations and labels were applied to the Affordable Care Act during the negotiations, and and to anything that cuts into the profit margins of private insurance companies, pharmaceutical companies, the same label applies. And one of the big, when this was first proposed, decades ago, by Harry Truman, one of the biggest organizations that was opposed and that used that language of this is socialism and communists taking over was the AMA. And one politician who got his start in the early 1960s, or actually I think it was a little earlier in the 50s, as like a spokesperson for the AMA against the communist takeover of healthcare was Ronald Reagan. So I think, you're never going to take away these kind of labels and labels that people are going to throw, but just, I think, being able to defend what the actual position is and to talk about how crazy and unjust our current system is. I think that's really key. I think to put someone in the position of, okay, well, tell me why what we have is a good thing. Tell me why people are really like benefiting from the current system and why you're comfortable with the levels of health disparities that exist now. And, again, I mean, you can call any name, but I think at the end of the day, it's no matter what you're calling it, it's growing in popularity because people recognize that there are huge deficiencies in our healthcare system and that we're kind of an international pariah. And that's also true of my take on global health, which I didn't get into. There's great global health work going on. If you're going and helping work on health systems in other countries, what is the credibility that someone from our health system has? And people know in terms of comparing us to the rest of the developed world, and what kind of moral authority and credibility do we speak with? And I would come back to that also.
You have been disconnected from the meeting.